Other way is if you bring the idea to the organization, right? So now you're not on their design team. It's not industry driven, but it's Dr. Satish driven. You say, look, I've got this idea. The idea is not just if it's really nebulous, meaning I've got this idea, I want to make a new glenoid. I mean, look, I think it's all based on your own individual personality. Some surgeons are really focused on learning the procedure, making sure you do every single step right, not deviating left or right from a single step. I said, wait a minute, 65 million French, maybe it's 70, I don't know, something like that. Let's call it 70 million French people have contributed so much to the field of shoulder surgery.
Like, what is the difference between if a surgeon is driving that innovation or if the industrial partners are driving the innovation? Like, or how does the process scenario changes between these two?
So look, if the industry is driving the innovation, they're going to say, we want you to come up with a new suture anchor, right? And they'll say, here's the basic design. We invite you to be on the design team for the suture anchor. And as it turns out, there are 7 people on this design team. They will then track your contributions over a period of time until the design materializes. And then you're set, as long as you have shown work, documented the work in email, through meetings, recordings, then they'll say, well, you've earned your 1% or your 1/4% or your 0.5% royalty on this because you were invited onto the design team. Sometimes before you go into the design team, they'll say, look, there's 4 of you, each of you are allocated 1% on this design. So there's 2 different ways that they'll do it. But in either way, it's really important for you as the surgeon designer to document each of the contributions and each of the meetings and the time you spent on this. Because if later on, as it comes down to a discussion of did you really contribute, you want to have evidence that you contributed in a meaningful way. Other way is if you bring the idea to the organization, right? So now you're not on their design team. It's not industry driven, but it's Dr. Satish driven. You say, look, I've got this idea. The idea is not just if it's really nebulous, meaning I've got this idea, I want to make a new glenoid. And they say, okay, well, we really like you, Satish. Let's have you join the glenoid team. And then it's going to be driven by them because they're going to drive the process. But if you come back and you say, you know what? No, I've got this idea for a glenoid. And instead of being curved back, instead of being flat back, it's going to be an undulating back. And here's how you do it. And here's some mechanical testing behind it. And here's some prototype. Well, now suddenly you're coming with IP, intellectual property. And if that IP is patentable, meaning if it's novel and interesting and you can file a patent, at least a provisional patent, which is not so hard, and that becomes unique special property, then you come in with the ability to command a greater degree of royalty. Now, again, it never goes to more than 2 or 3 or maybe 4% in an unusual circumstance.
So for a young designer, you've been through the 2 processes. One is taking the product to the industrial partner first, and the other is working with yourself, developing the product to the full form, and then taking it to the industry. So can you walk us through the other pathway? Did you have any product that you designed by yourself back in the lab and then took it to the industry later?
I have probably worked on 3 or 4 products by myself, not by myself, but with a team of friends that we subsequently brought to industry. In that case, once again, you need some capital, right? And you have a lot of ways you could do this. You can come up with the idea and the product and make some prototypes and get some data. Or if the other avenue is to say, look, I'm going to commercialize this product. Now that becomes very hard. And each time I've thought about doing that, I've backed away, because to commercialize a product, you really have to start a company. You have to have an insured company. You have to have a sales force that you're using, and you don't hire your own sales force in a small startup. You go to, there's a series of representatives out there whose job is to take on small independent companies. But that's a few $1 million. And if it's a great idea, it comes to great reward. I mean, look, I had nothing to do with it, but you look at this BioBrace company or this Regeneratin company, which are 2 products that are popular in the United States to augment tendon repair. And one sold for, I think, 115 million. The other sold for 250 million. Now, that doesn't mean they got all that money all at once, but be sure the surgeon creators did exceptionally well and got huge amounts of money. So there is a lot of reward in doing it yourself, but a lot of risk. The chances of a medical device startup company succeeding are about 10%, meaning 9 out of 10 fail. Again, that doesn't mean you should be discouraged, but in the beginning, you may want to try and learn the ropes of how a product is actually brought to market as opposed to jumping in. It also depends, again, on the product, right? If you're working, I think that individual products are going to always be exciting and be the need for development. But I think that the tech side of things is really where things are going to ramp up. And if you could develop your own tech side of things, then you don't need an industry partner for that. You need your cousin engineers in India.
So when you are prototyping it by yourself, then how did you take it up to the industry? After the prototype stage, did you pitch it to the industry that this is the final product we have and can you take
Look,
it?
you go and you sign a non-disclosure agreement. And then once again, you're going to go in and have a meeting with a PowerPoint and have a lab demo, and you're going to pitch it to 2 or 3 companies. You're not going to only let one company have the hands up, right? So you want to bid yourself against other companies, and you're going to see who's got a spot or a need for that product at that moment, right? So because you don't know what's in their pipeline, you don't know what they're developing, and you don't know if they've tried something similar. And you don't, when the cricket team needs a left-handed bowler, they will find that one specific position person, and that'll be more valuable for them. But if they don't need that, then at that right moment, then maybe you're not as attractive to them. So once again, being lucky and present, having your foot on the pulse or your hand on the pulse of what the market needs and where things are going, and what people want to do. 4 years ago, remplissage started to get exciting. Well, that's when someone with a lot of insight said, I better work on a technique and some anchors that are going to work very efficiently in remplissage. Arthroscopic bone block is a big deal right now, but the techniques to do it are very varied, and no one has ownership of the optimal technique. So that might be another area to start to work on. I think addressing Hill-Sachs lesions, another interesting. For a long time, people have been trying to come up with a subscapular sparing shoulder arthroplasty. We're still not there yet. There are a few surgeons who are extremely good and can do it, but the average surgeon isn't able to do it yet. So there's so much opportunity, and it's about the wherewithal and the energy and the excitement to try and get it done.
So as a surgeon, who should you have on your side to become an innovator? What should your ideal team be consisting of?
The first thing you have to do is identify a problem. So as you sit around, you're in a meeting and you're talking about things, or you're listening on a panel, and you listen carefully, and everyone's like, oh yeah, that's so hard. Oh yeah, this is a trick. Oh, putting that in. Well, hang on a second. That's when the light bulb goes off. You're like, wait a minute. Not only do I agree that's a problem, but this whole panel agrees with me that this is a problem. So the first is develop this great idea. Then you want to share it with 1 or 2 colleagues who are in there with you, who can help think about the problem in the same way. Once you've identified a problem in the thought process, any kind of local engineer, right? Anyone who's a biomechanical engineer, and there's probably no shortage in India, can really help you get the design right. And then once you make a prototype, prototyping things is not as hard as it used to be. You don't have to make a mold and have a factory, right? You can 3D print anything. And if you don't have your own 3D printer, you can go to the library or a local store, and for a small amount of money, get that device made.
Excellent.
What's the role of research in innovation? Like, how do you balance this evidence with intuition when creating something new for a problem?
It's a balance, and somehow, some way, you want to. Sometimes the evidence comes after the innovation, right? I think that the challenge is to identify the problem, and once you've identified the problem, then you can subsequently push forward on it. Like, we don't know for sure that the current polyethylene that we're using The vitamin E polyethylene is going to last longer in reverse arthroplasty than does the regular, right? But we believe it does. We can translate it across from the hip and knee world. So little by little, you have biomechanical evidence, which you can get before you get clinical data, and then ultimately you collect your clinical series to say it's safe and efficacious. So you follow your first 40, 50 cases, and then you look for longer term data. But you can't know 5 years down the road, so you just have to have grounded principles. And when you're so revolutionary, so transitional, then you've just got to be patient, and it's going to take longer.
Dr. Paul, like your story is very much fascinating. We just want to know, like, how much this fire caught on with your fellows or colleagues. Like, did you see the future of surgeons or getting more into being a designer surgeons, or what is the scope, or how do they react when you see a surgeon like that beside you?
I mean, look, I think it's all based on your own individual personality. Some surgeons are really focused on learning the procedure, making sure you do every single step right, not deviating left or right from a single step, using the exact anchor, the exact device, the exact moment that they were trained in. And I think there's some importance in not deviating from gold standards of surgery. At the same time, when you're doing something like, gosh, why is this step so hard for me? Step back and say, well, why is it hard for me? Are you doing something wrong? Are you positioning the patient wrong? Are you positioning the portal wrong? Have you done something imperfect? Or is it really hard for everybody? And if it's hard for everybody, that is your opportunity. Do other younger surgeons are they all in? No, some people, look, most surgeons don't like to do research. It's boring, it's tedious, right? The research I do, I'm not looking at lipoprotein A and its effects on the metabolic properties of the mitochondria and tenocyte, right? That's just not for me. My research has all really been based on, at least for the most part, like what's wrong? What am I doing wrong? What am I struggling with? And if I'm struggling with it, I bet someone else is. So let's figure that out.
That's a very good answer, Dr. Paul. So you're telling the research and innovation is going hand in hand with you. Like you're looking for problems when you do the research.
Yeah, I mean that's it. So that's what drives me. And other things are going to drive my friends, right? So some of my friends just want to be in the gym right after practice, and some want to be sailing on a boat or riding their bicycle for 100 kilometers. I try and have a balance, and I want to be with my family as much as I can. But at the same time, I've dedicated some energy towards my perpetual curiosity and perpetual interest in being better at what I do. So after every single case I do, even if it goes well, I regroup. And if I'm talking to myself or talking to the assistant or the fellow, I'm like, well, what did we do well in that case? Right? And what didn't we do well? And even if everything went perfect, what you did well, then you reinforce what you did well. And you reinforce why the approach and the angles were all good. And what didn't you well do? I mean, even if you thought it was a 90%, still a 95 you can make. So perpetually examining yourself goes hand in hand with my curiosity, wanting to learn more, why you do something some way, why someone else does something another way, and how that's going to affect your outcome. So that's what leads me to do any kind of research.
But when you look at orthopedic innovation, my perspective is that in the previous generation, there were more innovators, and now with big companies around, most of the innovations are being taken care of by the companies. And the number of designer surgeons are going down. So how do you think is the future of orthopedic innovation? How is it going to evolve? Are we going to have more designer surgeons, or are the engineers going to do most of the stuff and we're going to just use them?
You can't go anywhere without designer surgeons. You need us. I saw an interview and they said, okay, well, you have to take let's see, I'll ask you the question, Jerry. You have to take a lay person who's never done surgery through an operation. Can you do it?
It's a difficult.
And if you can do it, pick an operation. I mean, could you imagine taking someone who's never operated through, you're not allowed to scrub in, you can just use words, right? And teaching them, saying, okay, here's how you're going to do an ACL surgery.
Mm-hmm.
Well, sorry, it's a knee. That's a knee. You can't. I know you've given up on this too. Let's say on how to do a proximal humerus fracture. I mean, it'd be exceptionally hard, right? So I
Yeah,
think
yeah.
the role of surgeons and surgeon development is, as long as we're curious and fixing the problem, we've got to fix and identify. The engineers are not in the room with us. They don't know the problems. So now look, maybe they're going to invent a problem and give them a more expensive solution, but we've got to decipher the problems and then say, look, here's the challenge. And the engineering and the industry partner can say, well, if this is your challenge, we'll give you a solution.
Like, what needs to change in the education or in the training pathway to encourage innovative mindset?
I think the innovative mindset's embedded in the individual. So there are going to be people, just look, I give a lot of talks at a lot of meetings, right? I'm on this podium a fair amount. Some people much more than me. But the reality is that most people in the audience know the same that I know. They're just as educated as me. They've completed university and training and fellowship just like me, and they're going to work and doing these operations just the same as I am. So what is the difference between me and the person in the audience? And it's just that, it's maybe a slightly extroverted personality or some sort of fulfillment that I want to get by giving the lecture. Because I think that if I pick someone out of the audience, 85% of them can come up and give a lecture just as good as, if not better. So it's about what the individual wants for themselves. I don't know. What do you think? Do you think there are innovators and non-innovators? I don't know if you can create an innovator, Satish. What do you say?
Yeah, I agree with your answer. Like, it's always the person who defines their future, and it's hard for a training pathway or a course to determine where you have to be and how you have to be, because it's always the person who determines where he has to be. Yeah, I agree with that.
I mean, and Jerry, why did you make this podcast?
I'm this particular podcast with you or the whole Brew and Bones?
The concept.
The concept. Yeah, I mean, uh, during residency, I didn't know many things that existed, so I just wanted others to know it through the podcast. So I started interviewing. That's how it started, and it's going good.
So who told you to do it?
It's my own intuition.
It came, right?
Yeah.
So look, you guys are doing it. There's no teaching, there's no education. Like, look, we're going to do this. And, with the chances of something succeeding if you don't try are zero. So you try, right? And if you try and it works, I mean, fantastic. If you try and it doesn't work, you've learned a lesson on how to make the next try better. You don't get discouraged. Goes back to the no's, right? Like, let there be no's. Just walk around that person.
Exactly.
That's a very insightful answer, Dr. Sethi. So you have been instrumental in creating Indian American Shoulder and Elbow Surgeon Society. What inspired you to start such a society?
All right. And you told me you were going to ask this question. So I'm going to ask a question with a question, and then I'll give you my answer. Why did you apply for this fellowship?
Just because it's a great opportunity to get trained with you guys, to know how you do things on the other side of the world.
So it seemed like a good idea, right?
Yeah, wonderful idea.
And did you enjoy it?
100%.
And now you've made a lot of friends, right? You talk to all these individuals.
Yeah, I'm in touch with most of those guys and guys like you as well.
I mean, it's cool, right? So anyway, there I am in the meeting, and I hear a great lecture, a second great lecture, and a third great lecture. And all three lectures had one thing in common. Each of the lecturers had a French accent. I said, wait a minute. 65 million French, maybe it's 70, I don't know, something like that. Let's call it 70 million French people have contributed so much to the field of shoulder surgery. I mean, that's amazing, right? There's more than 1 billion Indians. And I'm thinking to myself, where are they on the podium? And I get a chance to go to Ganga Hospital, and I'm on the panel, and I'm theoretically meant to be an expert. And they show a very complicated case. And I said, oh, well, this is very hard. You have to stage it and be careful. And then S.R. Sundarajan says, oh, no, this is actually my case. Let me tell you what I did. And he shows me this unbelievably complex case that he did. And I said, well, thinking to myself, there's no way that person's going to be able to, they're going to be so stiff afterwards. And he shows the after result, which is a perfect result. And it dawned on me, I'm visiting a country of over 1 billion people who do high volume, high end surgery, maybe not all the time with the best technology. There's got to be more that should be being produced from India of 1 billion people rather than a country that made fantastic contributions at 70 million, right? So myself, Samir Nagda, Anand Murthy, we sat together and we said, look, let's create an exchange where we're going to learn what our partners in Asia are doing and where we're going to exchange our ideas so that cross-pollination can really happen and we can learn from each other. And that was born the IASES. Now we're in our 5th year. We'll have our 5th set of fellows coming in September. And gosh, I hope to keep it going. We also have our surgeons come and visit and attend courses, at least 1 or 2 a year. And I think we're going to be there'll be 2 at Ganga again. Last year they were in Delhi. I think not DAC. I think that's taken a lapse. But anyway, so it's a mutual exchange to try and position Indian and South Asian surgeons on the podium because of what they're doing and the talent they bring.
Like, what is your vision for the IASES in future, and how does such a cross-barrier academic community is shaping the future of shoulder and elbow surgery?
I mean, my vision is to have dual studies that go across 2 nations that encompass a wide variety of patients and techniques where we can make important statements on how shoulder and elbow care can be delivered. In the same way that our French colleagues have made fundamental, permanent, lasting changes to how we understand arthroplasty, I think the Indian surgeons can bring to the world an understanding of trauma and arthroscopy. And you as a group typically see pathology that's more advanced because patients there, and correct me if I'm wrong, and I don't like to generalize, but they'll often wait till longer, more advanced pathology, bigger tears, more than 1 shoulder dislocation before they even see you in the clinic. So I think re-understanding, how you will manage, I think, the patient with 5 or 10 dislocations arthroscopically still. And, here like, oh no, you have to do something different. You have to do Latarjet. So there's so much that you're producing in India. So I would love to see all of those tricks and techniques and data translate across. I mean, Sanjay Desai was giving a lecture one time and he's commenting on his Bankart repairs. And someone says, all right, well, what do you think? He goes, well, I don't know. I've done about 3,000. And and I stopped. I said, wait a minute, you've done how many? I said, oh, around 3,000. And I mean, there's no one in the world, literally no one in the world who's done 3,000 Bankarts. And there's this man, and he says, look, I use an open curette and really prepare the medial glenoid perfectly. And you guys will nod your head like, of course we do. We're all trained. Like that's what you do. But I didn't know that, right? I used a shaver and was roughing up the side. An open curette's elegant, perfect way, getting rid of the cartilage right at the margin so you can get it to heal up. And my results are better. It's just that simple. But so how many people, when you accumulate this together, can contribute that much? Well, the answer is a lot. There's so much to offer. And I want to have that bilaterality of exchange where we learn from each other more regularly.
Yeah, bilateral research can be a great thing to do. Thank you, Dr. Sethi, for creating such a wonderful organization. You are also one of the directors of Shoulder 360, a course that quickly became one of the most sought after courses in our specialty. How did that initiative start?
That initiative, I was invited by one of my craziest friends and one of my calmest friends. I'll let you guys guess, Abood and Mirzayan, who's the crazy and who's the calm. I don't want to say, I'll get in trouble from them. But we had a vision to create a course that wasn't droning on by a PowerPoint. It wasn't going to be the classification for a system is an AO 2.643, and this is what we were dying. We were dying in the podium, in the audience. It was fantastic. If you hadn't slept, you could go to the conference and sleep because they would just fire you to sleep. So the next thing is we said, look, someone gets up there and they say whatever they want, but it's not challenged. Like, how do I know your talk is good? So we said, okay, well, 1, it's going to be exciting. 2, it's going to be fast paced. 3, we're going to judge you, right? I know it's not a judging world. Everyone's good. Everyone gets a prize, but we judge you. And if you don't give a good talk, we tell you your talk's no good. If you had so much bias, we say, look, you developed that prosthesis. Of course you're going to say that, but here's the problems with that. So by creating this fast-paced, fun environment in Miami, we had a good time, and we thought this would be interesting. And in the first year, people were squirming in their seats and they're uncomfortable. They don't know what to think about. Now, as we head into this 4th year, 5th year, they're excited. We had the president of the Shoulder and Elbow Society dress up as a professional wrestler and give a lecture in wrestling gear. We had Andy Jawa. We put him on trial. And I don't know if you've seen any of the videos, but he had an orange jumpsuit, and he was accused of promoting reverse shoulder replacement for everybody. And he put on a case and said, listen, here's the data. You can't handle the facts. You can't handle the truth. He had a lawyer. Yeah, we had a judge, a jury. You'll find this eventually when we release the video. But what's happening there is we're debating in a fun way, should we be doing more reverses or more anatomic arthroplasty? But we do it in a creative setting, like the trial of Andy Jawa. There was people wearing T-shirts that said "Free Jawa." It was fantastic.
Okay, apart from being a jury or having informal conversations, what makes Shoulder 360 different from traditional surgical conferences?
I mean, it is a lot of information. It's action-packed. It's not boring. We're not afraid to be challenged. You don't just accept the status quo. If JP Warner, one of the most significant contributors, or Christian Gerber, these are both our faculty, if they're saying something that we don't agree with, we have a gong, we stop them, we say, hang on a second, you can't just say that, you defend yourself. So everyone walks out, everyone's included, everyone walks out feeling like they're a part of what happened there.
Like, you have been in this journey for a while, like being in this educational leadership, and how does it influence your learning and career?
Look, I'm lucky. I get to go to all these conferences, and I'm constantly hearing someone's thoughts and someone's process. And I get to see an idea that I'll hear 3 years ago start to develop, right? Similarly, I'll hear an idea that 3 years ago was a great idea, that the year later was still really good. And the next year, I'm like, hey, you didn't talk about this here. Oh yeah, no, I stopped doing that. It doesn't work anymore. So things don't ever make it to the literature, or you hear about things before they get to the literature. You're constantly challenging yourself on thoughts. I mean, again, going back to reverse arthroplasty, our understanding of where to put this and how to do this and what tension and what's lateralization, I mean, it changes maybe every 15 minutes. And none of us agree on any of these things. And we're just lucky that the implant is so forgiving and we get away with most things. But it puts me in a position to reach out to faculty from all over the world when I'm having a clinical question, a dilemma, and I can email, Robert Tajan from Utah, because I know him very well. And I can say, hey, what do you think of such and such? Or I can reach across to Ashish Bubakar and say, hey, look, what do you think of this? Like, what's your experience there? And these individuals, because they're also similar and curious, like, oh my gosh, here's what I think, Paul, blah, blah, blah. This is a great idea.
So the educational leadership is providing you connections throughout the world, and it gets you to the information that is not available yet on the literature, so you can improve yourself quickly.
I mean, you've distilled it, Jerry. You've distilled it perfectly. That is a huge advantage. I almost have insider trading, but it's legal.
Excellent. So you are also one of the most sought after mentors in shoulder and sports surgery. I guess you have fellows under you. And are there any short-term training options for people from developing countries? I could see some LinkedIn posts from my friends. They have been with you for a month or two. So how does that work out? And just offering this for others.
The challenge coming from another country is that the fellowships all are observerships, because unless you have US MLE and have a license, it's very hard to get the privilege to scrub in. So I'm frustrated about that, but so if you're a surgeon in South Asia, India, and you want to go do a fellowship, probably Australia or Europe is the best chances to do hands-on work. But that said, I've had for the past decade, maybe 15 or 16 surgeons over the years who have come and spent anywhere between 1 and 3 months with me. You can find me on LinkedIn or WhatsApp or whatever it may be. And look, you say, why do you want to, you send me a letter of interest. Why do you want to come? I want to see that you have enough, you have enough exposure, because if you're coming just to the very basics, it's hard, because we're doing so much complicated surgery that first you should spend some time getting the basics of the arthroscopy. But usually a month is okay. You find a place, Airbnb a place. It's a city of Stanford, and you spend a month and you see patients with me 1 day a week, and then we go to theater usually 4 days a week. There's no weekend responsibility, so you travel to New York City, which is 1 hour, or Boston, which is 2 hours. Go see your relatives. So many people have relatives in New Jersey. I don't understand, but they're all there. And it's a really nice experience, because you get to work one-on-one with me and my colleagues. There's 8 of us who do sports medicine surgery. So you get a few different exposures in sports medicine surgery. And it's been really rewarding. I've gotten to know people from all over the world. And I feel very fortunate to know those people.
Okay, do you prefer, or do you have any set of benchmarks to get a fellow with you? Like, is there any particular number of years of training he must have undergone, or is there anything
Look,
like that?
I like someone to have done. I like it best when they have either just completing their training, or maybe have had 1 year of practice, because you don't know what you don't know. And what I mean by that is, if you've not done enough arthroscopies or replacements, then the hard steps are like, oh gosh, I didn't know that was a hard step, or I wasn't seeing that one step that's hard. But now, after a couple of years in practice, you're like, oh, that retractor placed there, that's how you do that. Oh, that portal just the nuances and the subtlety of making things easy just are harder to appreciate. So I think, in the end of your training, or after a couple of years of practice, is best.
Doing a practice, being an innovator, doing research at the same time, and having multiple leadership roles. Those are too many hats to even count. So how do you balance all these?
And you forgot about being a husband and a dad and a son. Look, it's easy. I'm perfectly imbalanced, and in no moment is everything equal. So it is just the undulations of trying very hard to do as much as I can to be efficient and organized in my time and my thinking, and then try and prioritize. So, unfortunately, I can't say yes to everything, and I prioritize the things that I really want to get done, and then I focus on them. I try not to let things linger. If something is lingering around for a year or 2 years, I mean, like, if it's a research project that needs 2-year follow-up, it's different. But if there's an idea that I just haven't written the paper on, or haven't written the topic on, or haven't figured out, well, then it's just got to move, right? Because if it's not coming to, then it's not its right time. So execution, right? Execution is everything, at least in the business world. There's tons of good ideas. The hard part is, can you execute your good ideas? So I realize when I'm floundering or not executing, I'll just cut bait and move to the next project so I can get it done well.
But when you're doing multiple roles, how do you actually balance? Like, do you have a day for innovation? Do you have a day for research? Do you have a day to think on leadership roles?
Yeah, so far you said I have a day for research, leadership, innovation, family, surgery. I mean, right now I'm already down 5 days, and I haven't been in the clinic once yet. I have not shown my face in OPD, so I'm in trouble. So no, look, I compartmentalize, and I also have help, right? I've developed a good team. So I have 2 research assistants. I have a fellow. So I have a physician's assistant and an athletic trainer. So I have and you don't just walk in and get these things, right? You little by little build each piece, and when each piece becomes successful, or when you've really filled up the plate of the next individual, then you add that, right? And you say, this is expensive and it doesn't make sense, but each success builds more reward for the next one. So by having the right team in the OPD, then I can see 5 extra patients in a day. And if I'm seeing 5 extra patients in a day, then I'm generating the ability to add and to invest in myself, invest in my own business. So I think it's just about having help, having resource, and then being efficient. Whatever you're tasking, really get it done.
So I was speaking to Dr. Anshuman Singh from San Diego.
Yeah, sure.
He told he is inspired by you. He exactly told these words that the one thing that impresses him the most about you is how hardworking you are and how energetic, curious, and joyful you are in each situation. I mean, throughout this podcast, we can see that how true and curious you are to give the answers to us in a most humble way. Thank you for all the answers.
Thank you. I'm impressed with Anshu just the same. I was just emailing him about an hour before this. He too, this guy shows up at Shoulder 360, and I give him assignment. And he comes in a costume as a wrestler, right? And he's on the stage in front of a few hundred people and presenting at a very high intellectual level, but in this wrestler costume, right? It takes a lot to do that. I should gotta find the picture. Look, it's just about having the right, and I love it, right? These are friends and these are colleagues, and I like what I do and I'm inspired by what I do. So if I'm enjoying it, it's not really work. Some days it is.
Yeah, that was.
Some days it is, right? When that one patient just keeps giving you a hard time and so many questions, the 13,000th question about the rotator cuff, and like, look, I don't know. Maybe you go see OPS because he's a very IPS. He's a very nice man. You drive to New Delhi because he'll fix it better for you.
Thank you, Dr. Sethi. I think we have drilled you through so many questions for the past 1 hour, and you've been very humble and very true in your answers. You walked us through your true journey. We are very pleased to have you on this podcast. I think this podcast is going to send the right messages to the youngsters in India as well as abroad about innovation and leadership.
Well, I congratulate both of you on such fantastic early careers already. I congratulate you as innovators for starting this podcast, and I thank you both for humoring me with letting me come on your show.
Thank you so much. Thank you so much for your time, Dr. Paul.
Okay. All right, guys.